stepped into the next field, okay, of pediatric dentistry, a lot many people would wonder and talk to me, holding their hands to their jaws, realizing that this is how they are talking to me, and thinking that they are obviously in some form of dental pain. Okay, when I went into the field of pediatric dentistry, and I was introduced as a pediatric dentist and a very proud pediatric dentist at that, I could see so many people having images of a child who's screaming, crying, hysterical in the dental office. Okay, and they often ask me, how do you even manage to see children? Okay, or they imagine me having a clinic full of crying, screaming children in the dental office. Okay, of course, this visual of the crying, screaming child would quickly change into admiration when they realize, okay, and they ask me that how do you manage these children in the dental office, or even looking at the tiny little mouths, and let alone go about treating them. So these were the initial ideas. Okay, as I was getting into my practice of pediatric dentistry, and as I evolved my career in the last many decades. One important aspect that always stayed with me, it was one of the early learnings as a pediatric dentist, and I quote Dr. Michael Roy, who says that the pediatric dentistry or the dental treatment may be perfect, but the appointment is considered a failure if the child departs in tears. And this is something that has stayed with me. And I must say that this is the concept that most pediatric dentists, okay, in today's practice share, that their entire endeavor is to how to make the child uh, cooperative and happy in the dental environment. So keeping these, you know, thoughts in mind, when Dr. Rajul Javeri asked me to speak on a topic, I said, what can I share with a medical practitioner that would be interesting, and at the same time give them insight as to how we go about managing children in the dental practice. Okay, so the topic of my presentation is curating the dental experience for children, and I am a senior consultant at pediatric and preventive dentist and a senior consultant at the NHSRCC Hospital, Mumbai. Now, understand what pediatric dentistry is all about. Okay, it's an age-defined specialty that provides both primary and comprehensive preventive as well as therapeutic oral health care for infants and children through adolescence. Importantly, it's not something that is restricted to children who are as little as people ask me how often do you see children who are as little as 1 month or 2 months old, and we have treated children as little as 15 days old who have come with the presence of a natal or a neonatal too. The oldest children, okay, are the ones who are the late teens. Our specialty transcends the age group, okay, once we are dealing with or treating children with special healthcare needs. We have children who are treated at the SRC Children's Hospital with special permission. Those who have special needs who are 18 years and above 19, 20, because they are in the ones who need the help and the treatment from a pediatric dental specialist. So it is an aspect that is something that we must all keep in mind, and I will elaborate on it a little later. Now, why pediatric dentistry? What's so special? What's so different about it? Okay, yes, we understand that we are looking at and treating children who have the primary teeth and then transitioning into the permanent set of teeth. But importantly, okay, two different aspects have to be looked into. One is the treatment aspects, and the treatment aspects are going to be discussed by my colleagues, okay, a little later on in today's session. But importantly, what I am going to share with you and talk to you about is how to go about managing children. Okay. Now, managing children itself by itself is where I feel separates us from the rest of the adult dentists or other adult specialist dentists, because okay, when a child visits us as a pediatric dentist, our approach and way we manage the children makes them look upon okay the whole experience in a very positive manner. Now, let's understand where the first child parents dental experience begins. Okay, and let's talk about the first dental visit. Often I'm asked this question as to when do we bring our child to the dental office. Okay, how old should my child be when they should bring to the dental office? Now, the American Academy of Pediatric Dentistry recommends a dental home. Okay, and we call it the dental home because we don't want to call it referring it to the pediatric dentist. Okay, by the child's first birthday. So the first dental visit should be around the child's first birthday or generally coincides with the eruption of the first primary. Now, we have what I say is mandatory is that a child should visit a pediatric dentist for a routine checkup, okay, by the age of 2 years. Okay, sufficient primary teeth have erupted by then. Okay, it's important that we spend a little time counseling and advising the parents as what to expect, okay, going ahead. So it's important that we have a visit by the time the child is 2 years. And I'm happy to say that many pediatricians, okay, amongst us practicing in Mumbai uh, have a format wherein they recommend a pediatric dental visit or a pediatric dental checkup, okay, by the time the child turns 2 years of age. Often when a parent comes to me at the age of 2.5 or 3, they are at times a little sheepish saying, I'm so sorry, doctor, I'm a little late for the appointment. Well, as long as they come in early, okay, we can institute or advise them preventive dental methods. Now, let's look at, okay, one aspect is when we want to counsel the parents. Ever so often, we hear of parents portraying us, the pediatric dentist, as the villain or the dentist as the villain. Okay, it reminds me of, soja bache gammar aa jayega. And it's something like this that, if you don't brush your teeth, I am going to tell the dentist you haven't brushed your teeth. Or if you eat too many sugars and sweets, I am going to tell the dentist and you get caries and he's going to pull out your tooth. So one of the first things that we like to advise parents when they come in early and before child can really comprehend what the parents say is to not use negative reinforcement, okay, to make them brush their teeth. Okay, we tell them brushing of the teeth, something is that should be done as a routine, okay, both morning as well as at night. And of course, it should be done so that the child continues to remain a happy brusher. So we recommend and we request the primary care providers to refer the child to the dentist early enough so that we can advise them appropriately. Okay. One of the reasons why children tend to turn uncooperative is when they have heard of a bad dental experience. For some reason, sometimes parents feel that it is better to take them along for their dental appointments. And at times, dental appointments may not go as planned, may take longer. And especially when they see their child on the dental chair, okay, sitting for long periods of time, children do tend to get negative towards dental procedures. So, of course, it's definitely important not to take your child along for a dental appointment. And more importantly, okay, let's not wait till the child has an unpleasant dental experience. So that's something which we have to keep in mind when we are, okay, looking at uh, trying to inculcate a positive behavior for the child. Now we look at parental anxiety. Now we all know that an anxious parent, maybe the mother, maybe the father, is one reason why the child. Okay, it's very easy for the child to get the anxiety from the parent. As you can see in the picture out here, the second picture, okay, the parent who's sitting at the back, keeping herself or himself busy and not interfering or not involving, okay, one herself in the dental treatment, the child tends to learn to relax. Often I tell the parents, it's okay if you learn to relax, the child realizes that you are trusting the pediatric dentist, and therefore the treatment will go through smoothly. Often, if parents leave the operatory, when they get a call on the phone, they leave the operatory. You find that the child tends to become more and more relaxed, and the anxiety tends to lower. So maternal anxiety or parental anxiety has a significant influence on the child behavior. So they come and tell you, oh, I don't want to go to the dentist because I am so scared of the dentist, and they tend to blurt it out sometimes as a joke, as a conversation. So as a pediatrician or the medical or the physician, okay, you could counsel the parents, okay, not to say these things in front of the parent, in front of the child, because when they take the child to the dentist, they are listening to what you are saying. So they would then come in with a negative attitude towards dental treatment. Okay, now coming to the physicians, you all are the primary care providers. You are the ones who see the child first, and you're the ones who will make the maximum impact because the child has been coming to you from birth. Okay, the family physicians have the entire trust of the family with them, and therefore it's important that you make sure that they come in early. It's well documented fact that if a child has an existing dental problem, okay, the first visit will always be an unpleasant visit because they're coming in with the issue of pain or swelling or something that is bothering them then. Okay, so try, which is why I'm re-emphasizing and iterating again that it's important that you send the child in for a routine dental checkup when they are young and when they don't necessarily have dental issues and dental problems. So that's something that we need to keep in mind. Okay. Of course, please make sure that you refer them to a facility that has a uh, ambience that makes children happy and cooperative. A walk through the OPD clusters in SRCC, okay, will show you so many children sitting and playing so happily in the play area. And when they are waiting their turn to meet various medical consultants. And this is known to lower their anxiety, make them feel wanted, make them feel appreciate the environment that they're in. So when they come in to meet the doctor, and including us dentists, they are a little more relaxed. Instead of going into a general hospital or a general dental clinic, which is not geared to managing these children, okay, when they come and visit them the first time. Okay, today, pediatric dentists also around the city, around the world, are now aware of this. Okay, we all do realize that dentistry is at times a stressful experience because it's, as I say to all my other medical colleagues, it's probably the only real medical procedure that is carried out for a period of time with a child completely awake. And why the child? Let's be honest about it. A lot many of you may still be bearing the effects of having a dental procedure that wasn't as pleasant as you would want to do. Today, the entire approach to managing children on the dental chair has completely changed. And we, of course, in Mumbai and India, are using whatever methods we have available to us to make sure that the child comes in a happy, cooperative mood. Now, we have, of course, various methods of managing the children. I'm just not going to share it. I'm not going to burden you with all of that. But what's important is that we spend a lot of time in initial communication. Often parents come into us with the idea that they come in with problem and they want to get the problem attended to. But it's important to do an initial consultation wherein the child learns to experience what it is to sit in the dental chair and have the minimal number of instruments placed inside the mouth. At times, we don't even attempt to take an X-ray or a radiograph of the offending tooth because we want them to not have too many instruments put inside the mouth and have an unpleasant experience. Okay, positive reinforcement is something, and specific positive reinforcement is the word that we use because often we tend to tell them not to do a negative behavior or tell them to remind them not to do a negative behavior, but we forget to applaud them for a positive behavior. So we are very clear when we tell them when they sit on the dental chair and they open the mouth. First thing we say is, "Wow, you are opening your mouth so well," or you are allowing me to count your teeth so well." So these are specific important aspects that really help us, and we also want you to inform the parents today when they're coming in for the dental procedure. Very often they tell the child, "If you don't open your mouth, okay, the dentist is going to give you injection. So you better open it." Of course, today's parents are a little more sensitized towards it. They're trying their best to make it a little more positive approach. We need to, as we all need to inform them as if the first providers, and that you mustn't try and reinforce negative behavior. Okay. Whenever there's a sibling or an older sibling who sits well or a friend who's sitting well, we always allow the younger one to come in and view the treatment. And that's what we call modeling. And that's something that has always worked very well. So in the initial appointments when another child is on the dental chair who's very cooperative and the slightly apprehensive or the first time child, okay, is watching them, okay, this tends to reinforce good positive behavior. Okay. Now, very important is something that we always tell the parents, and I'm sure this is part of child psychology, is that we do recommend rewards, okay, and not bribes. Often parents, I have had parents telling the child that, if you allow for dental treatment, you will go for a holiday to the US. And if you allow for dental treatment, we will go to Disneyland. And that is more of a bribe rather than a reward. A reward could be a very small gift, or a very small little sticker, or maybe an outing that is done at the end of a successful dental treatment or a successful dental appointment. So we always recommend, do not. I have seen, okay, incentivizing the child in the beginning or offering a child a bribe, as I would say, never seems to work. It's always a reward at the end, an unexpected reward at the end of the treatment that really works well. Now, as far as we are concerned, we have cooperative children who can cope with a lot of dental treatment on the chair. We could be treating the entire mouth. They could have a 3 and 4 year old child who can go through multiple dental appointments, which may require simple fillings, to even the more complex root canals, as well as placement of crowns. Okay. But however, very small children, depending upon the age, children who are preschool, 3, 4, 5 years of age, by good care behavior modification, if you have minimal to moderate dental treatment, if there is extensive amounts of treatment, if a child comes in with what we call early childhood caries, something which my colleague is going to discuss a little later, that requires treatment for dental decay in multiple teeth, requiring multiple appointments, wherein, okay, a local anesthesia is required, all the appointments, then it becomes very difficult for the child to cope and cooperate for the treatment. So we as pediatric dentists, okay, try, and of course, we definitely try our best to make children cooperate on the dental chair. It's a feather in our cap when we are able to treat these children. Children who are apprehensive with coming in, we try our best, okay, using various methods to make them sit. But if a child is very apprehensive, then there are methods that we would like to use. Now, it's not that we have only definitely positive children who come into our dental practice. Okay, if that was true, it would be a dream job and a dream specialty to begin. We do have children, of course, who have their own challenges. You have, of course, we have a behavior rating scale which we use, and I'm just going to share with you. And depending upon their behavior rating, we kind of outline a management modality. So as you can see out here, if a child is definitely positive, okay, all we need to do is manage them correctly. Don't make a definitely positive child negative. Okay, that's important. Don't push them too hard just because they've come in and they're smiling and they're allowing for treatment. Don't expect to complete all the treatment in a short few appointments. Okay, try and break it up into manageable units, and that's what we always do. We have, of course, the positive child who sits on the chair, is allowing for treatment, but at the same time, you can sense a little apprehension, a little anxiety. And for that, we use what is called as a combination of behavior management and something that I'm going to discuss with you called nitrous oxide oxygen inhalation sedation. Now, these are different methods in which to make an anxious or an apprehensive child, okay, go from being a positive to a definitely positive child. Then, of course, you have a negative child who sits on the dental chair, but okay, we can see the resistance to opening the mouth, okay, difficulty in trying to follow instructions, or trying to simply delay the dental appointment, dental examination, running off, asking to go to the washroom, to the bathroom. So you would basically categorize that child as a negative. Now, this child would probably require a combination of nitrous oxide, oxygen inhalation sedation, or even at times we would have to take them into of a more pharmacological management of treatment, and that would be general anesthesia. Of course, we have a child who's very young, 2.5 year old child who comes to us crying and hysterical on the dental chair. It doesn't really make sense to try and force them to do any form of dental treatment. And then we have the option of treating them under general anesthesia. Today, a lot many children do get treated under general anesthesia, and then negative behavior, as I mentioned to you earlier, is sometimes often because of the fact that they have they are aware that they have multiple dental problems. Okay, children who have multiple dental problems are always going to be a little frightened because they know that it's going to involve certain treatment. Often parents have taken them to non-specialist dentists such as the general dentists who are very good in what they do. They are tuned into what pediatric dentistry treatment entails. So therefore, at times, having a previous negative dental experience also makes these children negative, and therefore they need the route of general anesthesia. Now, let's understand nitrous oxide oxygen inhalation sedation. I'm sure most of you are already familiar with it. Not of It's used very commonly for labor analgesia. In dentistry too, it has been used extensively for I think more than a century, and it is something that we are employing routinely in at the SRCC hospital, where we have one of the state-of-the-art units to try and make the slightly anxious apprehensive child into a positive cooperative child. Okay, and so when the combination of nitrous oxide and oxygen, when used appropriately, is an effective and safe mean of managing pain. So there's mild analgesia, and of course, most importantly, it works as an anxiolytic. Okay, often this term nitrous oxide oxygen inhalation sedation, or noise as we call it, is referred to as conscious sedation because the child is wide awake, watching, talking to us, following our instructions. At times there are television screens which we place above the child's head so that they can engage and cannot be distracted as they are watching, as they are doing the dental treatment. So therefore, this is a very good method of managing these children. These dental units that are specifically manufactured for the noise that we use, they have the advantage of a fail-safe cutoff at a 70% of nitrous oxide, which basically means that there is no chance of a child going into deep sedation. It's always something that there is a fail-proof mechanism which is basically placed. So we start off the child at 100% oxygen. Once we ensure that the child is breathing well through the nose, then we kind of go ahead and then slowly reduce the oxygen concentration while increasing the nitrous. For most children, the anxiolysis is achieved at 40% of nitrous oxide with 60% of oxygen. And if analgesia, when we want to give a local anesthetic, we may reduce it to do a 50-50 mixture, wherein a bit of analgesia is also achieved. And more often than not, children who are breathing well through the nose will not even feel a local anesthetic. Okay, so this is basically a little picture of how we do the nitrous oxide oxygen inhalation sedation, and it's important because the nasal hood is placed and the mouth tends to remain clear. We have good access to the mouth, and we can go about treating these children. So there is something that it's very good. What are the side effects? Often parents are asked us what are the side effects, and the side effects are at times related to a bit of gastric irritation, a bit of nausea and vomiting. It doesn't require a stringent NBM protocol. We, of course, advise parents before any dental procedure not to overeat before coming, because anytime placing instruments or fingers in the mouth can initiate a gag reflex, and vomiting on the dental chair is always an unpleasant experience. So we, anyways, recommend that you shouldn't feed right up to the dental appointment. And today, most of the kind of treatments that we carry out, fillings or procedures, allow for children to eat right away after the procedures. So this is something that we basically recommend. Okay. Another question that is often asked, and what is specific to our noise machines, which are meant for dental use, is that there is no nitrogen oxide, that tends to remain in the environment or in the treating room or the operating room. Often we don't have open windows and ventilation. But what we basically, like nitrogen oxide being a heavy gas, tends to settle to the floor, and there is a scavenging unit which is attached to these machines that tends to take away tends to take away the exhaled nitrogen oxide into the outer circulation. Through these machines, that are provided on the dental chair. Okay. Lastly, the safety as far as the use of nitrous oxide oxygen inhalation sedation is that it's got 100% record. So the use of pure noise the use of pure nitrous oxide inhalation sedation. Even anesthetists have shared and told me and advised me that if you use it alone without any other cocktail of drugs, it is an absolutely 100% procedure and therefore can be performed chairside and doesn't require to be done in the dental in the operation theaters. Okay, now this is a little video of a child undergoing nitrous oxide oxygen. It's, as you can see out here, I am informing the child what we're going to do, giving them an idea as to what they're going to feel, because nitrous oxide oxygen sedation doesn't entirely give them analgesia, doesn't numb them from feeling any discomfort or pain. So we need to basically use our behavior modification technique along with a combination of the laughing gas. So here, we are injecting a child, which is, what we consider to be a key procedure with the child remaining absolutely conscious. This is basically the use of nitrous oxide, this thing which has been a big boon to all of us in the dental profession. And of course, it's very important because children today, not many children are sitting and going through procedures without them having any traumatic dental experience. Now, let's come to a topic that is extremely close to my heart, and I talk about pediatric dental practice for children with special healthcare needs. Now, SRCC Hospital, Mumbai, with a large number of best medical specialists in the field of neurology or orthopedics and cardiology, okay, have a lot many children who come in. And as the pediatric dental team that works out here, we have to treat a lot of them, okay, because of course we need to clean out the dental mouth, remove any form of dental infection prior to them undergoing any form of medical procedures. Now, as I said, okay, there are children who range from those undergoing bone marrow transplant to a large spectrum of neurodevelopmental children. And of course, we are seeing a growing number of children that also have, okay, childhood autism. Now, unfortunately, because of the burden of medical care, what happens is that by the time these children come to us, okay, there is need for extensive dental treatment. Parents, because of their other medical conditions, either tend to neglect that, or often they tend to indulge their child, okay, with giving them sugars and sweets, not brushing, or finding it difficult to brush their teeth, allowing them to fall asleep with the milk bottle. That all tends to aggravate, okay, dental disease. And by the time they come to us, okay, they require a lot of dental treatment. Okay. Now, also there are multiple medical interventions tend to sometimes make them uncooperative because they've been seeing doctors from the time that they are little or they're born, and therefore by the time they come to visit us as a dentist, they tend to be very uncooperative. Okay, understand one thing, that while they have a medical issue that needs to be urgently dealt with, okay, the dental treatment needs to be done because any focus of infection in the oral cavity can lead to a failure of the medical procedures that have been planned. And a lot many times these children require to be treated under general anesthesia. Okay, interesting graph that we basically got out from the records at the NHSRCC Children's Hospital, Mumbai, is that from in the last 5 years, from 2019 to 2024, okay, more than 186 children, okay, who were treated under general anesthesia. Most of them were pretty cooperative, but a large percentage of these children were children who had special healthcare needs. So that's something that we need to understand, that these children form a large segment of the population, as well as those children who are extremely small, who are 2 years, 2.5 years old, and required to undergo some a corrective dental treatment, or what we call a complete oral rehabilitation, which may require general anesthesia. If you were to take a look at the distribution of the children who have special healthcare needs, you can see that neurodevelopmental disorders, unfortunately, are the maximum at almost at 72%. And you have other children also, okay, that form a part of this group that we've been treating. Okay, this is where we operate in the OTs at the SRC's hospital. We have an excellent team of pediatric anesthetists, very, very capable. I have been extremely happy working out here, and led by Dr. Nandini Dave, who I think leads from the front, is one of the top class pediatric anesthetists that we have. So this is basically the team that works with me. And we have, yes, at times, okay, the journey. So these children, okay, there could be special children who do not even allow for a initial dental checkup. An examination is tough for these children. Children who are hyperactive or children who are autistic, okay, they cannot be restrained because their hyperactivity tends to get aggravated and they tend to get aggressive if you try and restrain them and try and do a dental examination. So therefore, often what we do is we admit them into the emergency room just for a short IV sedation, wherein we do a dental examination, including X-rays and radiographs, and prepare and plan what needs to be done again. Sometimes, of course, even an IV sedation helps because not only do we get to know what dental treatment has to be planned ahead, but also the requisite blood work may be also done. Often parents request us to do blood work that has not been possible because of the difficulty in trying to get to get the so therefore these procedures can be done under the IV sedation. Now, uh, when the child is scheduled for dental treatment, okay, be it a pre-cooperative child, okay, a small child who requires dental treatment, or a special child who requires full mouth rehabilitation. Okay, the anesthetist team does a pre-anesthetic evaluation, and then in the pre-op OT with presence of the parent, nasal midazolam is given, which helps to make the child a little more sedated, and therefore the transition from the pre-op area away from the parents into the OT area is extremely smooth. Of course, SRCC has done a great job and done has now involved newer gizmos and this little battery operated remote car. Or of course, we have our child-friendly screens that can be used to take the child into the OT. As you can see out here, the child is driving under the influence, if I may say, of midazolam. What, of course, he doesn't know is that this car is being by the person walking behind him, and this is how we basically often take them into the sterile zone. Okay, the anesthetist team tells me that these little uh, additions have now even reduced the need for pre-procedural oral or nasal sedations. So that's something that is interesting as far as we are concerned. We basically have found it. Okay, the child goes in quite willingly to the OT, or it's not so traumatic trying to spray the child from the parent. Of course, as far as the dental treatment is concerned, we need to be aware of the fact that we cannot go back and do retreatment in the future. So we need to be very definitive about dental treatment because there is no going back. And so therefore, important we have the facility to take preoperative X-rays, radiographs if it's not done in the IV sedation before. Of course, for most children who are pre-cooperative but have allowed a dental examination, we take them into the OT, and once under anesthesia, we basically go about taking their dental X-rays, dental photographs, and the records, and then we cannot execute the treatment. So it's important that we make sure that definitive dental treatment is done so that when the child is out of the OT, there is no need for recurrent dental treatment in the near future. Okay. The good thing is when I'm asked this question that, will all the treatment be done at one go? So to answer that, yes, all the treatment is done at one go. We perform multiple root canal treatments, multiple crowns. Pediatric dentistry has their own crowns, which are specialized, prefabricated, ready-made, which are placed in the mouth, and all the treatment is done in one go. And surprisingly, what is interesting is that the child, when they come out of the anesthesia and they are in the post-operative area, they have only one concern is when the IV line is to be taken out. So the pediatric dentistry out there, I can say, is perfect, and it's the anesthetist now who has to get the IV line out. So this is something that we do on a routine basis, and it is extremely safe. We treated children who are as little as 1.5, maybe no, 12 months. I think one of the youngest children child we treated for the dental procedure was when they were as little as 12 months of age. Okay. Now we have treated multiple children who have comorbidities, and one such child who had a hypoplastic heart syndrome treated by Glen circuit was by what Dr. Nanini told me was one of the most difficult and fragile cases to be have operated for a dental procedure at SRCC. Now, what was interesting was, as you saw in the little video here, that the child's saturation, despite giving oxygenation, was as low as 78%. Okay, at baseline, and of course, challenging was the hemoglobin was 7, further adding to the risk. So therefore, okay, these kind of procedures are being routinely performed. The parent came to me uh, with the with a clear request to please treat the child because the child was unable to sleep for the last you know 10 to 15 days. Child had multiple repeated swellings in the mouth, and there was no way that we could keep prolonging the procedure, and therefore the anesthetist team took up the challenge of treating this young child and making sure that all the procedures were done well. Okay, this is basically the pre-op as well as this is the post-op of the child right after the dental procedures. And as you can see, the child, okay, once they come out of the dental procedure, okay, they tend to be extremely relieved that all the treatment has been sorted out and done, and therefore they are quite happy to sit for a dental checkup. So what we do recommend is that regular dental checkups right after that, so that once again we can examine and make sure that everything is going as per the plan. And this also helps in reducing the child's anxiety because when they come in and they realize that no treatment is required, they tend to become more relaxed and cooperative in the dental chair. And we have this little boy who is an autistic child, and he was treated under general anesthesia some time back, but now he comes in regularly to visit us in the dental OPD. And basically, with a little time, a little perseverance, and a little persuasion, they even allow a little bit of preventive dental treatment. So that's something which is very, very important. Okay, and that is why pediatric dentistry tends to focus on spending a little time, giving the child a little a little space to allow for the dental treatment. So you can see out here, okay, he's actually now opened his mouth and he's allowing for a procedure, okay, which is the preventive dental procedure. Now, we have so many of these children, and as we know, the childhood autism is on the rise. We have too many, a lot of these children who are coming in with autism. Initially, they may be reluctant to sit on the dental chair, reluctant to open their mouth. Even a dental checkup may be a challenge, and these parents, okay, fortunately understood what we were trying to do, and they came in repeatedly and eventually allowed for the entire dental treatment on the chair, and therefore it became a big positive experience. Now he comes in regularly, and of course, every new appointment, okay, we need time to break in with him. He does allow the treatment, and this is him giving us a little high five on completing the dental procedures. Okay. Last, sometimes we have children with a milder form of ADHD and autism, and they actually allow the dental treatment on the chair from the very beginning. So not every child who is autistic or every child who has ADHD or child who has a developmental delay necessarily needs to be treated on under anesthesia or needs an inhalation sedation, a nitrous oxide inhalation sedation. Now, this little girl, okay, with childhood autism, okay, is quite a character, I must say. We've been treating her for quite some time. She has her own little uh, scene before she settles down the dental chair. So much so that when she comes in here to SRCC for a routine visit, she insists now that some treatment has to be done. So she's just not satisfied with the dental examination, but she wants some procedure to be done on the dental chair. So whether it's a simple cleaning or a fluoride application, this is something that we always are looking at doing. So these are big pluses as far as we're concerned, and we find that there has been a great learning for us, okay, and a lot of positive feedback from these young children. So I'm going to conclude by saying that, okay, as far as you're concerned, the early referral by the primary care provider for routine dental checkups, okay, allows the pediatric dentist to provide preventive dental advice and anticipatory guidance specific to the child's age. Now, this is very, very important because we see, okay, areas where they have not been brushed well. We can, okay, tell them as to where they need to concentrate upon. And if there are any initial signs of decay, we can help to reverse these. Okay. Dental treatment can be performed either by using appropriate behavior modification methods. If a child is cooperative or even if a child is apprehensive, can be managed by a good approach by a pediatric dentist. Of course, there are methods such as use of inhalation sedation or even general anesthesia when the child is extremely fearful of dental treatment. So I must say that general anesthesia has been always been a part treatment protocol, but the use of noise has greatly reduced the number of children requiring treatment under the general anesthesia. Right. So with that, I'd like to say a big thank you to all the listeners. Okay, not only for myself, but from all the lovely children that are in retreat. Those of you who have tuned in late and are wondering who you're listening to, my name is Dr. Rrst Vyas, and I'm a senior consultant and head of department at the SRCC Children's Hospital, Mumbai. Thank you so much. I am going to now request my colleague, Dr. Sanchali Kapadia, who is also a practicing pediatric dentist, a consultant at the Children's Hospital, and who's going to take you through a very, very important aspect of what we see and deal and treat on every single day, titled Early Childhood Caries. Thank you so much, and I'll pass the mic on to Dr. Sanchali.
You see, good afternoon, and thank you all for joining us in this dental masterclass. Imagine a scene in which In your OP, a child walks in, is brought in at about 3 years of age with pain, fatigue, loss of sleep, loss of appetite, and irritability. A routine battery of tests really doesn't present anything, but an oral examination presents dental caries and an abscess. These symptoms are common, which mimic bacterial and viral infections, and these are often seen in early childhood cases, which is the topic of the day. We are going to get into the details of early childhood caries or early childhood decay, as we call it, and understand how is it that we can guide the parents to prevent this condition. Caries in early childhood has always been an enemy. Right from the time that it was first seen by an American physician in 1862, being given different names down the line. It has traveled fast, and in 1994, it was named as early childhood caries. Sorry for the interruption. So we've seen that the severity is immense. And in India, about 64 to 78% of the children are affected with early childhood caries. It's important for us to address this commonly occurring disease because it is a very serious thing amongst children, and children with early childhood caries will always have a tendency to develop cavities in their permanent teeth. So let's first understand what is early childhood caries. It's defined as the presence of one or more decayed, cavitated or non-cavitated missing teeth, which may be due to caries or filled tooth surfaces in any primary tooth in a child of 72 months or younger. So it means that in a child who may have just a white spot on a single tooth to a small cavity, like in the first picture, or a significant loss of tooth structure seen, all come under the umbrella of early childhood caries. Before we go into the details of how does it form or what can we do to prevent it, let's understand what is the significance of primary teeth. Why is it necessary for us to think about cavities in primary teeth? Are they going to fall out anyway? Primary teeth start erupting from the age of 7 to 8 months till the age of 35 to 36 months, where the dentition is complete. Permanent teeth start erupting from the age of 6 years and go on to 10 to 12 years. So the duration of time that the primary teeth are in the mouth is significantly long, during which a lot of changes happen in the child going into an adolescent. Teeth are important for mastication, speech, prevent infection, aesthetics, maintenance of the arch, and guiding the permanent teeth into the correct position. So, primary teeth are the foundation teeth and they have to be protected. To bring home the point how important it is that in case there are primary teeth which do show caries, leaving them unattended could create problems. Let's look at a short-term and a long-term effect. Short-term effect could be just as much as pain, infection, lack of appetite, poor appetite because of it, loss of sleep, emergency visits, hospitalizations. This might miss their school days. It might even need extraction, and this might lead to malocclusion because of loss of teeth. Treatment might have to be carried out under general anesthesia in the hospital setting. In the long term, poor oral teeth health and dental diseases can be carried forward to adult. This might be seen that the permanent dentition is also affected. The child's general health results in insufficient physical development, especially in height and weight. There could be increased time and cost to the parents. There's a potential to affect speech, nutrition, and overall quality of life. These can also cause unexplained recurrent fevers. In case there's an underlying medical condition, matters just could get worse. So let's understand the progression of childhood caries. It could initially begin with just a white spot on the tooth as soon as the tooth even erupts, or could go on to a cavitation. Structure loss could lead to most of the teeth also getting affected. The way the progression goes is that the lower teeth, the mandibular teeth, are protected by the tongue if the child is bottle fed and is given milk at bedtime. The maxillary teeth are the first teeth to be affected, with the anterior being affected first, followed by the posterior maxillary, and then the mandibular posteriors are affected. The mandibular anteriors are the last teeth to be affected, and these are severe cases of early childhood caries. As we said, it can begin as soon as the tooth erupts. So let's understand what is the etiology or what are the causes early childhood caries. They could be microbial, feeding, dietary, socioeconomic factors, oral hygiene measures. Coming to the first, microbial caries. This is the most important cause wherein Streptococcus mutans and lactobacilli are the bacteria present in the mouth. The level of Streptococcus mutans is found to be higher in children with higher caries. Hence, it is very essential that we try and control the Streptococcus mutant counts of infants and children as much as possible. Here, we can think about the vertical transmission which happens from the mother to the child. And the window of infectivity is from the time that the first tooth erupts till 36 weeks. It's essential that the mother maintains oral hygiene from early on, and also saliva sharing activities like tasting the food with the spoon, giving it to the child, or sharing other items, or even letting the child touch fingers into the parent's mouth should be discouraged. And not just mothers. We would also want expectant mothers to be counseled about the importance of oral hygiene so that their hygiene levels remain optimal. Just a simple routine of twice brushing, flossing once, and using a chlorhexidine mouthwash should be added. And this is essential for the entire family, not only for the mother. Coming to the next cause of early childhood caries, which is faulty feeding practices. This is related to bottle feeding. When the child sleeps at night, sleeps with the bottle, or is breastfed and sleeps in a reclined position, is breastfed ad libitum, and there is no cleaning happening after it. Milk pools in the mouth and remains there. This gives sufficient substrate for the microorganism to act, producing acid and causing tooth dissolution and cavities. We insist that bottle feeding should not be continued beyond 12 to 14 months of age, after which the child should be put on a sipper or a cup, made to sit upright, fed, mouth clean, and then patted to sleep. Saliva here plays a very important role. Like we know, saliva acts as a buffer. It's important buffering of the acids. It acts for clearance, and it also helps in remineralization. What happens at night is when the child is asleep with the milk in the mouth, the level of lactose in saliva is higher. Saliva, as we say, is reduced because of night, and the frequency of the feeds is very high. The time that saliva gets to repair is minimized, hence demineralization is more rapid, causing greater progression of decay. The third and the important factor, in spite of early childhood caries being microbial factor related, is the dietary factor. Because once the child gets older and is introduced to different kinds of foods, what is fed to the child is very different. We see sugar being introduced at an early age, hence we advocate that sugar should not be given before 2 years of age. A lot of Indian weaning foods itself contain sugar, which should be discouraged. We need to convey to the parents in very clear terms that certain do's and don'ts have to be followed in terms of so as to avoid early childhood caries. One thing that we have started noticing in our patients is that children as young as even 1.5 to 2 are stationed at a place with a screen in front of them and are being fed. be it at home, be it in the restaurant, the child tends to eat for a long time, starts holding food in the mouth and forgets the morsel in the mouth and starts pouching food. This can lead to increase in decay. The retentiveness of the food items offered also plays a role. Not just chocolates, but biscuits and chips, the entire packaged food is to be avoided if we want to stay away from early childhood kids. The age group at which children are even admitted to school is getting lowered. We see them being ferried from school to class, during which they eat on the go. There is no cleaning happening, and things like these, which are easy to carry and package, are open. All these practices should definitely be discouraged. Socioeconomic factors like lack of education can lead to lack of awareness, which increases the chance of dental caries. Along with it, lack of oral hygiene measures plays a great role in increasing the chances of early childhood caries. It's not only the lack of cooperation of the child in brushing and rinsing, but I would say it's the lack of awareness of the and persistence of the caregiver that plays a role. If the patient says my 3-year-old refuses to brush, we need to ask the parent that is it okay with you that he doesn't brush and does he get an option about it? It should not be done. Brushing twice should be non-negotiable. And importantly, the parents have to lead by example. Even rinsing as a norm has to be inculcated into the child's habit from early on, because even while traveling, if they can take a sip of water or drinking water when the child is slightly older, say, not a sip of water and a swish around and drinking the water itself can clean the mouth to a certain extent. Many kids do not even rinse their mouth after meals, which definitely needs to be changed. So now we've seen what is early childhood caries, what is the causes of early childhood caries. So let's get into how is it that we can prevent it. And it's actually very simple. An early start and regularity in simple cleaning is the key to preventing early childhood caries. For parents, we could put out the guideline that the sooner you start cleaning a child's and an infant's mouth, the easier it is to tune the child to cleaning procedure. As soon as the feeding begins, the gum pads, the tongue, and the palate should be wet with a moist cloth dipped in boiled cold water after every feed. This should be continued throughout. Even at night, the gum pads and the tongue and palate should be. Brushing should be initiated with the eruption of the first decimal stool. It has to be started off with a finger brush, and you could go on to a baby brush as is convenient. Difficulty in brushing is always experienced by the parent, but a couple of suggestions in positions for this for infants and slightly older children, depending on how they cooperate, is a knee-to-knee position where two parents or the caregivers can sit across on two chairs, and one parent is distracting the child and holding on to the hands gently, and the other parent visualizes every tooth and brushes it. If it's a single caregiver, they can even straddle the child on the bed with the hands and the legs being restrained to a certain extent. Fluoride is the most cost-effective and self-applied method that we have to prevent cavities at all ages. So the right way to use it and the right amount to use it is crucial to reduce the chances of progression. World over, the recommendations have gone from the first tooth for 24 months, the grain of rice, 1000 ppm to 2 to 6 years, pea size is the same, and more than 6 years, half the size of a toothbrush, 1000 to 1500 as the pediatric dentist recommends, depending on the caries risk of the child. Coming to the treatment, the ideal time, as Dr. Harsh rightly said, is the time where the child has no problems. The child comes in much more comfortable. The outcome is more happier. He gets comfortable in the dental setting. He gets to know us better without having the fear of they would touch us and it's going to hurt. So the best time to see is the eruption of the first tooth As such, if there is no decay, we have only a dieting and a brushing counseling session. In these cases, if we see that the grooves and the pits with the primary molars are very deep, we recommend a sealant application, which generally obliterates the grooves to create a self-cleansing area, making it a little easier for them to brush. Once decay sets in, then the cavitated areas have to be restored. Preventive fluoride varnish is recommended. Diet and brushing counseling is recommended along with flossing if the child is above 3 years. Fluoride varnish application can be a very simple procedure and can be carried out easily on the child. We also have in our arsenal now silver diamond fluoride in case of cavitated lesion, and for some reason the child cannot be taken up for treatment at that time. Silver diamond fluoride is found to arrest for healing various progression. It can be applied biannually. The downside is that it leaves teeth stained. But it can be used for a short while, after which restorations and comprehensive treatment can be carried out. If there are trainings required, there can be restorations which are done in tooth-colored materials. Some of them leach out fluoride. In case more comprehensive treatment is required, a pulpotomy or pulpectomy for teeth lesions, they need to be carried out with stainless steel crowns or zirconia crowns. And in case, unfortunately, a loss of tooth happens, then we need to use space maintenance to hold the space in the arch so as to avoid later malnutrition. Treatment can be carried out under general anesthesia in one session, the details of which I think Dr. Harsh has gone into significantly. So everything would be carried out in a single session, whether it is a filling, a root canal, extraction, space maintenance, and the preventive protocol. Everything is completed in a single session, very comfortably. One thing that we have to remember after this, after any kind of treatment, is that there are follow-ups required regularly for about 3 to 4 monthly to monitor habits, both hygiene and diet. The way we treat depends on the age of the child, the social behavior, and the medical condition. So whether we are treating the child on the dental chair or doing it under nitrous or general anesthesia will depend on all these factors. Coming to, I realize there are a couple of lines that Dr. Harshan may think on the same lines, but this is the differently able group, which I guess is close to both our hearts. So we would just, I would briefly touch upon this. This is about early childhood caries in the differently able children. These children are anyway, and the parents are overwhelmed with enough of medical issues of their own. Dental needs are often untreated, unrecognized. To add to it, because of the medical conditions, they could have a lot of tooth defects, they could be grinding their teeth, be fed mashed food, communication of discomfort is difficult, and some medication also could have its effects. This can lead to greater progression of decay, hence, it can affect the quality of life, increase the financial burden on the parents, and can complicate the medical conditions. This group, if addressed to or if checked up at the right time in the early stages, can greatly benefit because we would want to make a difference to them and not add to their problems, already overwhelming problems, by increasing their dental issues. So it's essential that we see these children as soon as they are diagnosed or at the earliest within 1 or 2 years. So we as pediatric dentists look up to you all, our medical teams, to act as a bridge between the child and us. General practitioners, pediatricians, all of you have been seeing the children from newborns to families. So like he said, the trust factor is very high. A single nudge from your side regarding the importance of primary teeth, taking care of primary teeth, and the fact that they need to remember that they need to be attended to can make a great difference. Counseling parents and their children about the prevention of dental disease and early dental problems and so to conclude, messages, Enough that needs to be related regularly changing age, not just the child, but the entire family. Exactly. Early childhood caries. Very good afternoon to everybody. My name is Dr. Manini Shah, and today I am going to talk about first responses in dental trauma. What to do when a dental trauma visits your practice. So, uh, unfortunately, dental trauma is a very, very common and a true dental emergency. There are not many dental emergencies, fortunately for us. Dental trauma is a practice that we get follow after. Coincidentally, 1 year back, a child who was in my practice was back there was profuse bleeding in the upper area, and as you can see, the tooth is bottom driven inside the socket. Initially, the parent called us and told us we could not see this was out in the kindly action and infection has caused this tooth to erupt again. Wow. Traumatic dental injuries are now the fifth most prevalent disease in the world, but they are still being limited. Recent publication in Global Health has highlighted that traumatic dental injuries are now fifth most disease, especially after caries, tension, anemia, and age-related Very good afternoon to everyone. Sorry for the technical glitch. I'm going to read so that not my name. My name is Dr. Manini Shah. I'm a consultant pediatric at the SRCC Children's Hospital. And my topic for today is first response when dental trauma visits your practice. Now, dental trauma is a one true dental emergency which visits our practice very, very often. And it is for the clinician as well as for the child and the parent, because there is a lot of bleeding, the mouth is very vascular, and there are times when the child is inconsolable, we do not know what to do. Just a week back, we had a young 1-year-old child with a tooth which was driven inside, actually inside the tooth socket. And the parent called vehemently scared, saying that we cannot see the tooth seems to be missing. Profuse bleeding, and we counseled the parent, calmed them down, told them to come and visit our practice. After a week, the tooth is seen again in the mouth, self-erupting or spontaneously erupting. Traumatic dental injuries are now the fifth most prevalent disease or injury in the world, but they are being neglected. Recent publication, the Lancet Global Health, is now the fifth most prevalent disease or injury after caries, tension-type headache, iron deficiency anemia, and age-related and other hearing losses. World over, the prevalence of traumatic dental injuries is as follows, with American country having the maximum traumatic dental injuries with 19.1%. India is not far behind with 13% of traumatic dental injuries. Out of these injuries, the most common age group for dental injuries to happen is in children who are less than 6 years of age, with the incidence being at 15%. With children greater than 6 years of age, the incidence is at 12%. And the most common injuries here are uncomplicated crown fractures of the maxillary central incisors, which are the upper front incisors. Least common injuries are luxation injuries or teeth which move either actually inside the socket, out of the socket, or in and out occurrently. Who are the first responders to an incident of dental trauma in a child? Very, very commonly, pediatricians or family physicians, which are you all listening to the lecture, are contacted by the family, because you are the ones who know the family closely, you are the ones who know the child right from birth. So, very common call comes to you. The second commonest site for having trauma is in schools or family of the child, which if the trauma happens at home or in a playground. The third is the parent rushes the child to the emergency room, where the doctors and the nursing staff of the hospital, not necessarily dentists, have a look at the child. Now, to all these entities, the person that the child needs to be sent to at the foremost is the dental office, because the dentist is the one who has to look at this trauma. Different cross-sectional studies conducted across the world have shown that after an incidence of dental trauma, most patients report to the dental office after 1 or 3 days. Only around 1% of the patients report within the first 3 hours, which actually shows that they do not know the importance of visiting the dental practice that urgently, because they feel that, oh, nothing's happened. It was just a minor bump. There's been no bleeding. The tooth is very much inside the mouth. The child is fine. The child could eat. There was no pain. The child has slept. But these are not the only things that need to be looked into. Dental trauma needs to be monitored closely. Whether it's a milk tooth or a permanent tooth, it needs to be looked into. A baseline examination is mandatory, so that if there is any prognosis which has to be good for us, the trauma needs to be seen at the earliest. Because time elapsed since dental trauma is equivalent to bad prognosis. What is the role of a first responder in oral facial trauma? History taking is the key, because we need to know where the trauma happened. Was it a deliberate push? Has it happened in a garden? Has it happened in school? Where did it happen? Has the tooth fractured? Physical examination of the injury is very, very important. More important than the teeth are treatment of injuries to the brain, spine, limbs, if the child has lost consciousness, if there's nausea, if there is loss or slurred speech, that supersedes our management of dental injuries, obviously. The dental examination, if there is a medical issue, can then be performed concomitantly with the same IV sedation or GA, along with the other concerned medical professionals. How do we examine the oral facial structures? We gently wipe the child's face and the oral cavity with a gauze to remove any gross debris that is present. Pressure can be applied using a damp gauze to stem the ooze of blood from traumatized dental tissues. Deep lacerations, where there is extensive loss of soft tissue, need approximation of the edges, because otherwise the edges do not heal well and there is secondary healing. Suturing can be done with the help of an oral surgeon, pediatric dentist, a general surgeon, or a plastic surgeon, depending on the extent of the gash. What is the role of the first responder? Again, diagnosis, which is to find out whether a tooth has moved, whether it's only a soft tissue injury. Implications have to be explained to the patient if you are seeing the child before the dentist. Implications basically entail counseling the parent to go and visit the dentist as soon as possible, because if there is any emergency management which needs to take place, it needs to be done at the earliest. What are the various types of trauma to the dentition? A tooth can break, which is the most common dental trauma. Fractured tooth, which I've mentioned in point number 1, can have nerve exposure or pulp exposure, as we call it. The tooth can be missing in toto, or the fragments may be missing with the parent not have found the fragment. Or luxation injuries. Intrusion is the most common one, where the tooth gets driven inside the tooth socket. But there are other luxation injuries which we are going to touch very soon. Now, if a patient calls you and tells you, okay, we've broken the tooth, what do we do next? Very, very important for you to tell the patient that if you found the tooth excellent, do not let it dehydrate. Maintain it either in the child's oral cavity, if the child is old enough to hold it in the oral cavity, or keep it in water, keep it in milk, or keep it in HBSS solution, which is easily available in chemists. What do we do with the broken fragment? Broken fragment looks like this. Very commonly, I have seen parents coming and telling me that, doc, we found the tooth, but we threw it because we did not know any better. We did not know that it could help you in any way. And at that point in time, we were so flustered that we did not know what happened to our child and we just threw it out of frenzy. Now, this particular diagnosis is an uncomplicated crown fracture where the nerve or the dental pulp is not involved. What are the implications? Cosmetic, of course. The child or children nowadays are very, very aware how they look, how they feel, and how they want to look when they go back to school, when they meet their friends, when they meet colleagues in classes, and so on and so forth. For them, fixing that tooth is the ultimate key. How it's fixed, how long it's going to take is not something that they're worried about. They want their tooth fixed. They want their face to look as normal as it was before. The second common point for us is function. Front teeth are required to bite, so function needs to be restored again. In this particular scenario, since the nerve is not involved, there is no emergency as such. But like I said previously, dental trauma of any sort needs to be seen by the dentist as soon as possible, because sometimes there may be microscopic nerve involvement or a pinpoint nerve involvement, which you as a primary caregiver or the first responder may not be able to see, the parent may not be able to see, but we would want to see it so that there is no repercussions later. The broken tooth fragment must be stored in water or saline to maintain hydration till seen by the dentist. How do we fix it? This is a scenario where the upper maxillary incisors, both the right and left, were broken without any nerve involvement. One tooth fragment was attached, it's called fragment reattachment. The other one was built up layer by layer. This is another scenario where one maxillary incisor has a minor angle chip, where the other one is broken down substantially. Again, we build these two up layer by layer, restoring strength and function and aesthetics of these teeth. Now, very commonly, the parent comes to us and tells us, the tooth has broken, we are seeing it, but we do not know where the tooth is because there is profuse bleeding. Now, if a tooth or teeth are fractured, fragments of the tooth substance can or may have been dislodged from the socket and they've not been recovered from the accident site. We need to look inside the mouth and try and find them. First thing is a scenario like this where you can see the tooth fragment embedded in the upper lip. An X-ray was taken just to know the extent of that tooth fragment size, to know whether there's any other fragments embedded anywhere else in the upper lip. Soft tissue, including the lips, should be checked in case they are lodged there. Radiographic evaluation may be needed if the doctor is still unsure as to where the fragment is, just to rule out that it's not embedded into any soft tissue in the mouth, because that's then a foreign body, it needs to be removed. Now, a second scenario is a fracture of the enamel dentine, and now you can clearly see the red exposure, which is the nerve inside the tooth, is open. Now, what we do diagnose this as, it's called a complicated crown fracture, complicated primarily because the nerve inside is exposed to the oral environment and it needs timely intervention. Here, timing is key because if the child comes to us early, within the first 1 hour to 4 hours, and if a tooth is still for the tooth socket, we can maintain the vitality of this tooth by doing what is called as a pulmonary. Referral to a pediatric dentist is the key here because a delay in treatment is associated with poor prognosis, but the tooth formation is left incomplete because we did not treat this tooth early enough. The broken tooth fragment must be stored in water or saline to maintain hydration, and like previously mentioned, reference to the dentist or the pediatric dentist in this case is of utmost importance. This is a very, very common traumatic dental injury where the tooth gets driven inside the dentist. Very commonly, parents say that I cannot see the tooth because, as you can see, only a sliver of the tooth can be seen in the mouth immediately after injury. Now, what do we do in this case? Since it's an intrusive luxation, the tooth has moved in axially. We've got to make sure that it doesn't injure the developing permanent tooth because we need to see the action of the milk tooth driven inside. It can very commonly be mistaken for a missing tooth, where the parent may say, we do not know whether the tooth is lost. While the tooth may be observed for spontaneous eruption, we necessarily wait for 4 weeks for the tooth to erupt into the mouth. Some teeth may not move into its position and then need to be moved out surgically. If there's no tooth movement after 4 weeks, or if there is a change in color of the tooth, if you start seeing an abscess or a gum boil or a pus boil, if you start seeing on an X-ray that the tooth is getting dissolved internally, it needs to get treated. This is a child who met us 2 days after trauma with the upper milk incisor driven inside. On an X-ray, if you can see, the tooth not only has gotten driven inside, but has gone in oblique. After 2 weeks, you can start seeing a gingival bump. After approximately 2 months, we started seeing the tooth coming out on top of the other maxillary incisor. This needed a surgical extraction because the child was still 3 years of age and this tooth was not going to be of any help. It was causing damage to the developing permanent. What happens if a tooth is missing or there's complete tooth loss? This is the most important and the gravest of emergencies in a dental practice. And very commonly, a permanent tooth like this can be lost. Sometimes, unfortunately, both the upper central incisors may be lost. Now, this diagnosis is called avulsion or loss of tooth. Again, timing here is of prime importance. If the child can reach the pediatric dentist in the first 15 minutes, that's the golden period, because a tooth out of the socket, even when maintained in saline or in the oral cavity or in milk, it does tend to dehydrate because the entire tooth is now out and the periodontal ligament fibers do not get reattached very well. There are times when we've got calls from patients saying that we were so flustered and worried that we pushed the tooth inside the socket immediately at the site of trauma. I tell them, excellent, you've done the best thing that you could do. So if a child or a parent calls you and if they visit you first before they come to the dentist, or they do not have the dentist, or they are very away from the dentist, they are out of town, tell them that if possible, if they are not very worried, push the tooth inside the socket because that's the best place for the tooth to be held. They may push the tooth in a wrong fashion, but it cannot go any other way. The gold rule here is that the crown portion of the tooth, which is seen in the mouth here, is what can be held. The root portion, which is the cone-shaped structure, should not be held because that's what the tissues or the cells which help in getting attached the periodontal ligament in the tooth socket. If the tooth is replanted by the patient or by the primary caregiver, refer to the dentist immediately for evaluation and further treatment because it needs to get splinted. The tooth is not going to hold itself there. If unable to reimplant, store the tooth in milk or saline or water. Keep the tooth moist. Now, how would you, as physicians or pediatricians, know whether it's a milk tooth or a permanent tooth? Because a milk tooth necessarily does not need to get reimplanted, or rather should not be reimplanted. Because a milk tooth, if reimplanted wrongly, can cause irreversible damage to the developing permanent tooth, which is sitting right above the milk tooth. Here, the age of the child is of consequence because between 6 months to 6 years of age, primary incisors are present in the mouth, both on the upper and the lower jaw. Morphological differences are the size and color of the teeth. Primary teeth are pretty small and they are whiter in color, which is why they're called milk teeth. Permanent teeth are yellower in color and they are large. Also, if you can see in these pictures, the primary incisors have a straight incisor edge, or the edge of the teeth is flat, whereas the permanent incisors have 3 bumps. To be precise, they're called mamelons because they are formed from 3 different parts. What is the treatment protocol for avulsed permanent incisors? First things first, pick the tooth up using the crown or the white portion without touching the root, which is the conical portion. If the tooth is dirty, rinse the tooth under a gentle stream of cold tap water. Do not scrub the tooth clean. We do not want a clean tooth because in the process of scrubbing this tooth, you are going to remove those periodontal ligament fibers. Once the tooth has been reimplanted, ask the patient to bite down on it using the gauze or cotton. Ask the patient to immediately visit the dentist for further treatment. At the dental office, this is what is done. We implant the tooth under shock, rigid pressure to be precise. We splint these teeth. We recall these children in a week. But this splint is a flexible splint and it is usually removed after 2 weeks or a maximum of 3 weeks. If the concerned tooth is identified as a primary tooth, we do not reimplant the tooth back into its socket. We compress the socket by applying gentle pressure using a damp piece of gauze. And we refer the patient to a pediatric dentist for further counseling or necessary action. If reimplantation cannot take place at site, if the person on site is unsure on replacing the tooth in the socket, they're worried, they do not know what to do, which side goes in where, ask them to store the tooth in milk, coconut water, or patient's own saliva if the child is big enough to hold the tooth in his own mouth. Avoid the use of tap water or saline as these may damage the cells of the periodontal ligament that help in the attachment of the tooth to the socket. Ask them to reach their nearest dentist within an hour as prognosis of a tooth improves with early reimplantation. It's very simple in this. I'm going to just tell you dry time. If the tooth is out of the mouth for longer than an hour, we still reimplant it. But what happens is that there is a lot of replacement, resorption, or dissolving of this tooth which occurs in a permanent tooth. And then ultimately, when the child is 12, 13, 14, we do lose these teeth. So time is the key. Early intervention is what is very, very crucial in reimplanting these avulsed permanent incisors. How do we prevent a traumatic dental injury from happening? Here, I've told you about what to do when there is a problem, when trauma actually occurs. But there are a lot of children who have their teeth which are slightly out of their mouth, who have their lips apart, they cannot shut their mouth, who breathe from their mouth, which causes the lip to always be open. And if these particular children are playing contact sports like football, hockey, basketball, baseball, soccer, martial arts, even rhythmic gymnastics, we recommend that they all should have a mouth guard or a sports guard made to size. Custom made mouth guards or sport guards are made by the dentist. An impression is made and it's sent to the lab, and this fits snugly onto the teeth. Instead of the teeth taking the brunt of the trauma, guard takes the force of the trauma. There are a lot of mouth guards which are available in sports stores. Unfortunately, they do not fit very well, or they can fit half the time out of the mouth. So we recommend making a custom-made mouth guard for these children who are into competitive sports or who are into a lot of contact sports. Make sure that the mouth guard fits well and is not damaged or distorted, because if it's damaged or distorted, it's not serving the purpose of saving your teeth. These mouth guards or sports guard also have to be maintained clean. Never, never, never wash them with hot water, because that's how it gets warped or distorted. Prominent teeth or teeth which are proclined or which are coming out of the mouth are very likely to have damage. There are a lot of children who have punitive habits like thumb sucking, thrusting their tongue. These children ultimately, when they start having their permanent teeth, have a upper jaw which is slightly more pronounced, thereby causing their upper permanent incisors to be that much more out. Orthodontic treatment is of optimum importance for these children because it reduces the risk of dental trauma in a big, big way. Always wear a protective headgear which is suitable to these sports, and do not place foreign objects in the mouth. A lot of children do that. I know of a lot of children who open bottles with their teeth, a lot of children who bite their nails and eventually have chips in their teeth. Dissuade them from doing so. Now, if I'm a first responder, how do I know what should be done? There is a lovely app which is available on Android as well as Apple devices, which is called Tooth SOS. This is something which a patient can also download easily on the Apple Store or the Google Play Store, where they can actually select what the problem is, or you as a primary caregiver can download these. And how to prevent this injury is one which is very important to me. But the second is, if it has happened, what to do next? If a tooth is out, what to do next? Yes, referring to the dentist is a key, but if the child has come to you first, what to do next? This is something that you can do till they come to us, till they come to a dentist that is known to you all, so that the child can save his or her teeth and can maintain aesthetics and function of their teeth in a better way. Thank you so much for patiently listening to my lecture. My name is Dr. Manini Shah. I'm a pediatric dentist at SRCC Children's Hospital. Thank you so much. I am now going to introduce to you the next speaker. His name is Dr. Chintamani Kale. He is a consultant orthodontist at SRCC Children's Hospital. And his topic for today is orthodontics and tethered oral tissues.
Good afternoon, dear colleagues. I am Dr. Chintamani, consultant orthodontist at City Hospital, and I am very happy today's topic of rapid maxillary arch expansion. This is especially for our young children who come to us with problems of chronic nasal obstructions and typically as what we call it as adenoid cases. So as an orthodontist, basically you would be finding a lot of work on children with braces and orthodontic appliances to essentially give them a very smart and smiley, pearly smiles. And we have a very fun and interactive way of working. So it's always good time with children all around in the clinic. Today's topic is about helping these preteen children with nasal obstructions. Typically, they present to us in our clinics with enlarged adenoids. They are chronic mouth breathers, and this causes narrowing of the maxillary arch. Because of the narrow maxillary arch, we also see children with a slightly retroplastic or the lower mandible, that is the lower jaw is slightly placed in it. And typically, the roof of the mouth has a very high connective wall, and it causes a lateral constriction of the posterior teeth as well. On the lateral cephalogram or the jaw X-ray, typically you would also see a very narrow airway, especially in the posterior pharyngeal wall, where typically because of the adenoid enlargement and the lateral adenoid tissues, we have a very narrow airway constriction over here. This typically causes the child to be a mouth breather that drops the tongue behind, it drops the lower jaw behind, and that's how we see them in our clinics. So the concept is that we would do a rapid maxillary expansion of the upper arch, and this would increase the nasal floor space. This causes improvement in the airflow through the nose. Simultaneously, as the maxillary arch is expanded, the mandible gets a chance to move ahead, and this basically would help into the advancement of the tongue forward into the oral cavity and clearing the nasal, the posterior space and allow the child to breathe properly. Overall, it would also help in the treatment of the adenoids, which is done by our colleagues, the ENT surgeons, as well as the pediatric physicians. And this is like a supportive treatment for these kind of children. So as our plans, if you look at the case selection, we are looking at an orthopedic widening of the narrow parietal shell, which is by application of pressure on the deciduous posterior teeth. The ideal age for this appliance is between 8 to 11 years. This is before ossification or the complete fusion of the two maxillary parietal shells happen. And the concept is the expansion is done by using a specifically designed screw appliance, which is stuck or bonded on the upper posterior teeth. We have an initial active phase of expansion, which is for about 15 days, in which there is a kind of a jamming of the teeth to the bone, and then the pressure applied by the appliance to the teeth is transmitted to the palatal bones, leading to widening of the two arches and stretching of the arches. In about 2 weeks' time, we see a good amount of stretching of the maxillary arch. That's why it's called as the rapid maxillary arch expansion. And then we have to wait for the consolidation by which the new bone formation happens. This is a small video which would show the method in which the appliance is it works. Essentially, we have a appliance which is bonded on the upper posterior teeth, and then there is a small screw mechanism. So there is a duration of about 4 turns in a day, which amounts to about 1 millimeter of expansion every day. So this expansion would be carried out for about 2 weeks.
So which gives us roughly about 10 to 12 millimeters of expansion. We do a slight amount of over expansion by which you see the widening of the upper arch happening, characteristically seen by the gap in the upper sagittal incisors. Later on, with the uh, settling of the front incisors, the new bone formation happens. So typically, this is how the child who would come in. They could see the upper arch is narrow, constricted. There is overlap of teeth, and we also see the posterior part of the pharyngeal area, which is completely constricted because of the narrow upper arch. After the expansion happens, this is typically the separation of the two incisors, which is characteristic for the rapid parental arch expansion appliances. This indicates that the parental shells they have split apart, they are separated, but because of the intact mucosal tissues, there is stimulation of bone formation at the margins of the split protective cells, and this helps in the widening of the arch. And again, we see a clearance of the posterior pharyngeal space because of the expansion. Because when we expand the upper arch, it not only widens laterally, but it also advances anteriorly. So therefore, it frees up the posterior pharyngeal space. It allows the lower jaw to again move forward, and that causes the tongue and the lower jaw to advance high. Typically, when I see a patient, this is at around 10 to 11 years, young boy, typical adenoid face features. You can see how the expansion has taken place after about 15 days of maxillary arch expansion appliances. This is the classic kind of presentation. When I do the maxillary arch expansion, you see a wide gap between the two upper incisors, indicating that the palatal shelves has separated away and there's a new bone formation. After about 3 months, I just keep the appliance passive in the mouth and we see that the uh, teeth are just floated down into the space created after expansion. And naturally, because of the force of the adjoining gingival tissue, the teeth just come down together. And that's how we are ensure that the results of our maxillary expansion have allowed the front teeth to start settling down. This is like a first phase. Then we have a phase in which I would maintain the arch expansion, followed by comprehensive orthodontics. So typically, this is at the end of the whole treatment. When I have finished with the orthodontic treatment, I have settled the teeth, and you can see the wide broadening of the maxillary arch into a proper U-shaped arch, and also you can also see the clearance in the posterior pharyngeal area. Now, because the whole upper arch is widened up, the lower jaw is moved ahead. So now the child is no longer a kind of a obstructive breather, but is having a more comfortable breath for it. Also, another case where similar, you see the wide expansion. This causes freeing of the mandible, the lower jaw moves ahead, and you can see the increase in the posterior airway. So this appliance is basically a very comfortable and complementary appliance for your chronic patients with chronic mouth breathing as well as upper airway obstructions, especially because of the enlarged tonsillar spaces. Here you could see this patient where there was hardly any airway available. She had a very narrow maxillary arch as well as was locked in behind the lower jaw. With the rapid maxillary expansion achieved, we could see the change in the arch shape from a very narrow V-shaped arch to a nice broad maxillary arch. And the lower jaw also unlocked and allowed for the airway to be freed up. So this appliance is very comfortable for children. It helps very much with children with adenoid enlargements. And this is like a pre-orthodontic treatment appliance, and it helps in our future comprehensive orthodontic treatment for the children. Improved breathing and jaw posturing helps in overall health of the child and development of the facial structure. The recently trending topic related to sleep apnea treatment. This also can be helpful. This appliance can be helpful in benefit of this young children. Here is a boy who was referred to me because he had difficulty in sleeping. He used to get up in the middle of the night, gagging out. Typically, a sleep apnea case. Overtly, he was pretty obese and overweight. At 10 years, he was about 80, 90 kg weight. And this is how his uh, airway space was. You could see there was heavy enlargements of the tonsillar region. And I had placed him on the maxillary arch expansion appliances. And once the expansion was done, he could, the feedback I received was that yes, now he was definitely comfortable and his breathing has improved. He has less episodes of sleep apnea. And that's how we are looking at the further treatment and settling down of his bite with regular orthodontic. So this appliance is part of the orthodontic treatment options what we have. And in our clinic, we do enjoy working with children. We watch them grow. And this is my wife, Dr. Rupali, who is helping me as a pediatric dentist at our clinic in Bandra. And at SRCC also, we have a nice, lovely setup. So I urge all the pediatric colleagues to be interactive. And my skills as an orthodontist would help you all in your handling of patients with chronic nasal obstruction. Thank you. I would now hand over to my pediatric dental colleague, Dr. Nikhita Gune, for her next talk. Yes.
A very good afternoon. A very good afternoon. When children of different ages visit a pediatric dental practice, very often the imagination of the dentist is captured by dental decay. This is the first thing that we look for. And when a mouth like this is put in front of us, it becomes very difficult to look beyond. Even if we have maybe a cleaner mouth like this, probably our attention would be first drawn to the plaque deposit seal and maybe the child's obvious orthodontic needs. But beyond that, lately, our attention is also being focused on this tiny thread of tissue, which you see in the photo above. In the last few years, every pediatric dental checkup now involves making sure that we lift the lip of the child or ask him to raise the tongue and check for this tiny thread of tissue, which we call the freni, or also called as tethered oral tissues. As checking as the evaluation of freni or tethered oral tissues in the oral cavity has become a mandatory part of checkup, so has the frequency increased of release procedures, and this is seen in global statistics across the world. This has prompted certain articles, including one in the prominent magazine called The New Yorker, which headlines "Inside the Booming Business of Cutting Babies' Tongues." And there are a few more. This has led to a debate on whether a dental frenum or the tethered oral tissue really needs to be released. And in this presentation, we look at the same and maybe try to come across on what would be the indications for this procedure. When would we actually consider releasing it? When could we let it go?
and what should be the protocol. Tethered oral tissues are basically a remnants of oral embryological tissue, which is normally we see it in the midline, in both the maxilla and in the mandible. So with the pointer in the maxilla, you see it, it's called the labial frenum, and it's seen just below the upper lip. In the lower arch, it is seen on the ventral surface of the tongue, and it's known as the lingual frenum. Is this an anomaly in the oral cavity? Not really. Every child and adult has these present. When our attention gets focused here only when these attachments hinder any kind of movement or function of the child. We also have buccal frenum which are present, and these are seen on the right and left maxillary and mandible buccal areas. To simplify, basically in the region of the cheek, they connect the gingiva to the cheek. How do we actually decide whether a particular frenum which is present in the mouth is really hindering any function for the child? While first we look at is anatomical classification. For a lip tie, what we basically see is where is the tie attaching. We have a classification given here. So type 1 ties, if we see, attach only in the pre-gingiva, quite close to the lip. We have type 2 ties which attach little below, somewhere between what we call as the pre-gingiva and the attached gingiva, right here. These type of ties generally will not hinder any functioning for the child. But we also have a class 3 type of tie. Here the renal tissue goes right between the two central incisors of the teeth and could hinder function. And then we have a class 4 tie which goes right behind and attaches to the hard palate of the child. A simple test that can be done in a clinical setup or at home to check whether any function is being hindered is to simply lift the upper lip of the child and stretch it outwards towards the nose. As seen in this photo, you can see some blanching which is seen here, indicating that this is definitely a restrictive tie. Along with this, symptomatically, the child would often complain of pain when you perform this test. Does these kind of ties really affect the orofacial development? Well, yes, it could hinder a child from establishing a knack while breastfeeding. Later on in life, it could affect sucking motions, maybe by a stomach. In terms of orofacial growth development of the face, generally what happens is the lip is always being pulled upward, leading to what we call as a short upper lip. And generally the child's lips tend to remain open. And further on, this could lead to mouth breathing in the future. Dentally, what we see is these parents often complain of difficulty in brushing teeth. As every time they lift the lip, the child may complain of pain and become a little non-cooperative. And certain studies have documented an increase in dental caries in children with restrictive ties. Also, due to the tie placement, you may see a gap between the front teeth called a midline diastema, which has aesthetic connotations. And you could also see a little pulling of the gingiva called gingival recession. So we see the gum line slightly receding faster in these spaces once they reach a adolescent or adulthood stage. For a tongue positioning, what we check for a tie is that first we need to see what is the normal or physiological position of a tongue. Ideally, a child should be able to rest the tongue on the hard palate. So we have a diagram here which shows the rest position of the tongue. The tongue is completely in contact with the palate. And then we have a second diagram showing a low tongue posture. The tongue is lying low on the floor of the mouth. In terms of when you check a child, the child should be able to lift the tongue and touch what we call as the tongue's home or the spot, which is basically up here in the palate behind the second root case. But this little behind the central incisor teeth for reference. How do we classify again whether a tongue tie is restrictive or not? There are two factors. One is the tongue elevation. So is the child able to elevate his tip of the tongue to the palate, the spot which I showed earlier? So if you see in this diagram, in grade 1 and grade 2, the child is able to elevate almost between 100 to 80%. As we go below, the elevation height decreases considerably. children with maybe a grade 3 and grade 4 elevation may find it would be considered to have a restrictive diet. The second factor that we look at is whether the child is able to place the entire body of the tongue on the palate and still open his mouth. If you can observe the diagram, as the level gradation progresses, though the person featured in the photo is able to place the tongue along the palate, the mouth opening continuously decreases, showing that he faces a restriction or hindrance in doing so. What would be an easy way to evaluate this clinically? While the classifications are great, especially with younger children between 3 to 5 or 3 to 6 years of age, asking them to perform these maneuvers may be a bit complicated. In this case, if there is a tie which joins the tip of the tongue to the alveolar ridge or behind the teeth, that's easily observable just by observation. But for what we call as a posterior tongue tie or more posteriorly placed ties, what can be done is that the child could be placed in the mother's lap, and you could simply use your index fingers to elevate the tongue to the palate. If you feel any kind of hindrance there, it indicates that the tie may be present. Also, this kind of thread of tissue will become prominent when you perform this activity. So this would be an easy way to evaluate in a clinical setup. What are the dental or orofacial problems you feature when you have a restrictive tongue like this? Often the children report to us with speech issues. So certain words such as SH, CH, which require either your tip of the tongue to touch the palate or the entire body of the tongue to be raised there. Children face difficulty in pronouncing these words. And there may be complaints coming in from school, from parents, particularly those who speak Marathi and Hindi at home. These speech issues are more prominent because these languages require better tongue placement to the palate than maybe the English language. We often see dental decay prominent in the posterior teeth of these children as they are unable to place their tongue, unable to move their tongue laterally as seen in this picture. So this is a self-cleansing mechanism in the oral cavity. So this often gets hindered. You may see a low tongue posture like with this child, particularly when they are sleeping, as since the tongue is not in its rest position, it may protrude between the teeth. The dental connotations could be that these, because of the child thrusting the tongue between the teeth, it could lead to proclined teeth and also poor palatal development, leading to a V-shaped arch. So do we need to release every lip and tongue tie that we see? Not really. What we look at the functional and whether functional and dental indications are present and whether it will improve the orofacial development of the child and his quality of life. When would we consider releasing a lip tie? So it would probably be the class 3 and class 4 lip ties, which we mentioned earlier, where the tie is attaching to the hard palate or between the two teeth. Many of these children may have dental decay. And if we see them at an early age between 2 to 4 years, they may not really cooperate for treatment or dental care. As was discussed earlier, if you're taking a child under general anesthesia for dental treatment, and they have such a lip tie present, we could consider releasing it as an auxiliary procedure to ensure that maintenance of the oral hygiene happens more easily in future. Children with an everted upper lip like this, where there's a notching seed and lip incompetency, again, a release could be considered for these patients. For a tongue tie release, first and foremost, we'll be looking at children who are referred to us by the speech therapist and are persisting with clarity issues. So while a tongue tie is present, there can be some compensation and not every child will have an issue with all the tongue tie is present. But if after repeated speech therapy, the outcomes that the child or the speech therapist want are not being achieved, a release should be done. But it's never prior to speech therapy. 1 or 2 months speech therapy should definitely be attempted before any release is done. Such kind of heart-shaped tongues where you can see that the child is unable to protrude as well as the tip is attached to the alveolar ridge are clear-cut indications for release. Tongue posture is what is there. So we often, again, a low tongue posture while sleeping could be considered an indication for release. when we are doing, we generally ask, when we're checking for tongue posture, we generally ask the parent to record a video while the child is sleeping at night, particularly in young children. And this will give a more true picture of how the tongue is being positioned. What is up for debate really here is whether a lip and tongue tie release help in breastfeeding. As of now, there are no clear-cut answers available, but it has been documented in different consensus guidelines by different organizations that difficulty in breastfeeding is a multifactorial condition. It could be caused due to maybe dysphagia, due to reflux, and many different medical conditions, which go beyond the scope of evaluation by a dentist. So any child reporting to us with a difficulty in breastfeeding, first we would consider rather we always refer it to a pediatrician or a pulmonologist. Eliminate any medical cause that is present for the same. If there is no identifiable medical cause and we can identify that there is a restricted lip or tongue tie present, we still wouldn't go ahead and release it at the first shot. We would go to a lactation consultant. In our experience, we've seen many children coming to the dental OPD even at 5 to 6 years. Maybe at this stage, they are coming to us with a speech issue. But if you take breastfeeding history, you will find many parents saying that they had absolutely no issues with breastfeeding. That definitely indicates that presence of a tie doesn't mean that breastfeeding is not possible. Many times, simple exercises given by a lactation consultant or a change in positioning can help. If this too fails, then is when we would consider going in for a frenectomy and release a tongue tie which may be present. Before the release, we will also advise orofacial exercises, myotherapy exercises to the child and parent, which we'll be discussing further. Just to summarize, even the American Association of Pediatrics and our dental association, the International Association of Pediatric Dentistry, recommend the same, that the first line of treatment should always be conservative management after all medical causes have been evaluated. Surgical intervention is a reasonable option only after all others have been eliminated. But would just releasing a lip or tongue tie improve function? Well, not really. It's like if I have a bad handwriting and I change my pen, will that really help? No. So similarly, when there's a tongue or lip tie present, what happens is that the child right from infancy may develop certain abnormal patterns, muscular patterns, which interfere with the normal growth and development. And often these patterns are deep set. Just releasing a tie may not help. What we need to really do is help recapture those original physiological patterns that should have been developed. For the same, what we recommend is doing a series of exercises prior to any tongue or lip tie release. Also, once a release has been done, you would have an open wound in the oral cavity, and there is always a chance of having a reattachment happen. Orofacial myotherapy exercises help in eliminating this and prevent any kind of premature attachment. Just to go through quickly the exercises which we prescribe. So the exercises would differ in each age group, depending upon the motor communication abilities of the child and the intellectual development. So for infants or younger kids, even till maybe 3 to 4 years, the exercises primarily we need to be done with the aid of the parent. Simple exercises for tongue tie release include simply asking the child, placing your thumb or a finger along your upper palate and asking the child to suck on it. This improves lip tonicity. Other exercises include passing your finger against maybe the lower arch of the child's mouth, and you would find the child's tongue going along with you. This is done to help improve the ability of the child to do tongue lateralization, move the tongue from side to side. And lastly, and the most important, is what we call as tongue stretches, where just like as we did in the examination, you can place 2 index fingers below the ventral surface of the child's tongue, like mentioned here, and raise it right up to the palate. In older children with other abilities, we do a series of different exercises. One are simple tongue raises, as the boy here is doing. simply raising the tongue towards the palate where the tip should ideally rest. It would not be very easy for the child to do this at first. But if it's done prior to surgery, he is more likely to be able to repeat these patterns post surgery when there is a wound in place. We also ask them to do tongue suctioning, where we ask them to place the tongue along the palate. We also ask for tongue clicks, where we ask the child to raise to the palate and create the noise, which you can see in a video. This is also a fun exercise, making it an interactive activity phase. For a lip tie release as well, exercises are needed. If the child has developed lip incompetency, that means there's a gap between the two lips when the child is in a rest position, we need to improve the competency. This may be simply holding a piece of cardboard between the lips while they are seeing TV or doing their homework. Simple exercises like these can be given. For the actual wound and for the lip stretching, again, we ask the parent to raise the upper lip upwards and outwards a bit, and also perform a finger sweep where we move the finger along the area of the wound just below the lip. These exercises, the duration depends on the age of the child. For younger children, we may give it just 1 or 2 weeks prior because the muscular patterns are not so inherent. In older children, you can give it for even 1 to 2 months. You will get better results with that. And for those who are undergoing a release for the purpose of improving speech, it should always be combined with speech therapy. Post procedure as well, the exercises need to be performed right from that same evening and continued for at least 4 to 6 weeks. There may be some discomfort, but if the child has done the exercises prior, he'll definitely find it much easier. And we, in fact, ask them to do it at a higher frequency post procedure. Is there any evidence supportive of myotherapy right now? While research in this field is definitely still emerging, we do have a series of articles now which show that when a surgical release is combined with these exercises, there are significant functional improvements seen in the child's speaking capability in speech and on other orofacial functions as well. With this, I would like to conclude and say that while a tongue and lip tie releases should be performed only when you have a specific functional and dental indication and outcome in mind, when done, definitely combined with myotherapy exercises, and we definitely will see better results with the same. I would just like to ask, are there any questions? They can be shared in the chat box. All our panelists are available here, so if you want to speak to any one of them or have any questions for either of them, we could take it right now. You could either unmute yourself if possible, or you could share it in the chat box.
Thank you so much for a very patient listening. It was, I think it was an enjoyable session for us. I hope you all enjoyed too. And there were a few take-home points that you could apply in your practice, be it for trauma or managing children with early childhood caries. I think, of course, the introduction of the rapid maxillary expansion as well as the concepts behind whether to or not to release tethered oral tissues is something that is trending recent nowadays, both in the dental as well as in the medical specialties. So I hope that when you see a patient next, you will keep this aspect in mind and do the necessary appraisal. Okay, thank you so much.